This conference will now be recorded.
Okay, so welcome to the class, all of you. So this class is about explanation of NICE guideline and also eclampsia, and also it covers the question answers. Okay, so now coming to the classification of hypertension in pregnancy. Okay, so it is real important to find out, whether it is a hypertension. It was there before pregnancy, so the, or it is a de novo hypertension that has arisen in the pregnancy. Okay, so according to the classification, if the hypertension is present before pregnancy or it present in first 20 weeks of pregnancy, okay, then it will be chronic hypertension. Chronic hypertension, again, two types: essential, so most of the cases will be of essential hypertension, and secondary if any associated pathology is there. Okay, and white coat hypertension, when the patient has high blood pressure when she comes to hospital or clinic on the because of that particular situation, fear, she has a hypertension, so that is a white coat hypertension. Okay, for our this from our class point of view, white coat hypertension hardly makes any sense. Okay, so important to know if it is before 20 weeks or present before pregnancy, so it will be chronic hypertension. And if it is coming after 20 weeks, so it is pregnancy induced. So pregnancy induced hypertension we again divide in two parts. One is gestational, another is pre-eclampsia. And only the difference what is there in gestational hypertension is that blood pressure will be high only, there will be no proteins on in urine, or there will be no protein in urea. But if blood pressure plus protein urea is there, and that too after 20 weeks of pregnancy, then it will be preeclampsia. Okay, so it's a basic thing, but it is really important because sometimes, when you solve questions, so the treatment for gestational hypertension and preeclampsia, it is different. Okay, so there, if you don't read the question well, the period of gestation, protein, amount of protein that is present in the urine or not, so that part has to be read very carefully when you answer questions. Otherwise, there is a very minor difference and the answer becomes wrong. Okay, now coming to chronic hypertension, as I already said, it is hypertension that is known before pregnancy or it is present before 20 weeks of first 20 weeks of pregnancy. Now few things that is required, and you will get question from here also, like in the part 2 also this type of questions come, and also in the part 3 stations, if the this kind of station comes that the patient is already taking some medication, that will either belong to ACE inhibitors, ARB, or thiazide group of diuretic. Okay, so these if your patient is taking these kind of medications and she has come to you before she plans for pregnancy, so you have to stop all these medications. Okay, and now from where you will get question, from this line: stop antihypertensive taking ACE inhibitor and ARB if they become pregnant within the 2 days of notification of pregnancy. Okay, so if the patient is coming to you before pregnancy for counseling, stop them. But if the patient becomes accidentally on the medication and accidentally she got pregnant, and if she comes to you, so you have to stop ARB and ACE inhibitor within 2 working days. So from this part you will get question. Okay, apart from this, now why there is so cute, why we have to stop them within 2 days time, or why? This is the answer for it. So ACE inhibitors, these are usually if she takes them in second or third trimester of pregnancy, so it causes toxicity and renal damage. Okay, therefore it should not be taken during the second and third trimester of pregnancy. But ARB or angiotensin second receptor drugs or ARB, they are not considered to be very good, and there's so many side effects are there because of this medication. So what can happen? It usually cause effects baby's kidney. So renal failure will happen. There will be oligohydramnios. There will be lung dysplasia. There will be cranial hypoplasia, limb contracture, and neonatal death. Okay, and why that I already told that is happens because of the fetal hypotension, reduced blood perfusion to fetal kidney. So fetal ischemia, fetal kidney ischemia, and urea oligohydramnios. Whatever the situation happens, that happens because of this condition only. Therefore, ACE inhibitors, they cause so much of damage. Therefore, this medication has to be stopped within 2 days. Okay. Now, one time I have seen a question where they asked the craniofacial deformity was because of which medication. uh, One time I saw a question, there is a problem with the skull ossification. So which drug affect skull ossification? So this all the answer for all this will be ARB drugs, and these are the angiotensin 2 receptor blocker drugs. And how these drugs are working? These are working because they block renin angiotensin pathway. Okay, so much detail is not required. What required for you guys is that you have to stop this medication within the 2 days of notification of pregnancy. And if the question comes about this thing, about so much of like cranial or problem with the skull ossification, craniofacial deformity, contracture, lung dysplasia, so your answer will be ARB, ARB group of medication. That will be the answer. Okay, so from here you will find question. So in part 2 a question comes from here, and in part 3 usually if the role player is taking this medication, so usually she asks, what can happen to my baby? So you have to give this kind of answer that because of this medication baby's kidney will be affected, and because of this so many problem can happen. Okay, so therefore I have put this slide. And yeah, this is not from the NICE guideline. Now if the patient has chronic hypertension, how you will treat the patient? Okay, so first of all, what are the thresholds of the treatment? It is 140 systolic blood pressure and 90 or higher diastolic blood pressure. Simple to remember. And what is the target for us? So target will be 135/85. So this is the target. So for part 2 people, they have to remember the values as it is, because they ask question from every line. Okay, now if the patient has chronic hypertension, what will be your drug of choice? So first line, we already know it is labetalol. Second line, if the patient says no, I have got problem, I can't take labetalol, it will be nifedipine. And one clue you guys have to remember here. So whenever you write in your answer labetalol, please check whether the patient is asthmatic or not. Purposely in part 2 questions, SB or EMQ, they will put this like patient is on the asthmatic treatment. Even same kind of station had come in the part 3 also, where the patient was asthmatic and you have to prescribe antihypertensive. So be very careful with this asthma. So another medication that is a last choice if the patient is not taking labetalol or nifedipine, so it will be methyl dopa. Okay, in our previous days of practice, we also have used this medication methyl dopa, but now it is not the first line. Now the first line is labetalol. So this is the hierarchy of treatment. Okay, first line labetalol, second is nifedipine, third is methyl dopa. So this you have to remember. So for part 2 people or part 3 people, this will be important. Okay, so that will help in answering your questions. On the other side, like this point has been added in this guideline, that if any patient, if you see a patient who has chronic hypertension, you have to start with the aspirin 75 to 150 daily, and from the 12 weeks of pregnancy. This is like this is the only treatment that is offered as a for the prevention of preeclampsia. Okay, so why it is we are offering this aspirin? This is for the prevention of preeclampsia. Now, so many of the people, they ask question like what is the dose? So these doses are not on the basis of hypertension 75 or 150. It is on the basis of BMI of the patient. If the patient's BMI is high, so so it will be higher dose of aspirin. Otherwise, it will be regular 75 dose of aspirin, 75 milligram dose of aspirin. So these are the key points that you have to learn, and with this, you'll be able to answer questions. Now, one important thing that you have to come new in this guideline is PG IF testing. There is a placental growth factor based testing, and usually this why this testing is done. What is PGIF? I'll just explain that as well. So this testing is done to rule out that what are the chances that this patient can develop preeclampsia, and this test is usually done between 20 up to 35 weeks of pregnancy. So this is newly added in this guideline. This was not there before. So in our upcoming slide, I will just explain details about this PIGF also. Okay. Now, what will be the schedule of appointments if a patient has chronic hypertension? So if it is poorly controlled, you have to see the patient frequently, so call her every week. But if she's a stable patient, so you can call her every 2 to 4 weeks also. This part is again has come new in this guideline. So part 2 people will get question from here, and part 3 people, if the patient role player station comes with chronic hypertension, so you have to tell them frequency of clinic visits, so that there you have to use this knowledge. Now, coming to the timing of birth, usually what they want that if the blood pressure is less than 150, 160 and 110, then it should never like a birth should not be offered before 37 weeks of pregnancy. Okay, so until the blood pressure is lower than 160, 110, we are happy, and we'll just say, okay, please take this pregnancy up to 37 weeks of pregnancy, weeks of gestation. But so this is from this line question comes, and part 3 people have to explain this to their role player. Another situation where patient has a chronic hypertension. Now their blood pressure is also controlled, and term like 37 weeks has already been passed. Now what to do in that particular situation? It will be gradual assessment of the patient as a whole. So there will be discussion between obstetrician and the patient when the delivery has to happen. I have seen question one of the EMQ from this line also, like the patient has a chronic hypertension, she is already 37 weeks past, so now she wants what to be done next. So answer will come, a timing of like she has, it should be a plan that is agreed between women and the senior obstetrician. So this was the answer for that EMQ. Okay, now anytime if the blood pressure shoots up, or any like maternal or fetal, any concern occurs or any problem occurs, you have to offer preterm delivery. Okay, so if it is a preterm, remember two things: you have to give corticosteroids or magnesium sulfate, both of the medication. So you will like part 2 people will get question from this line also. Okay, all this thing has come new in this guideline. Previously it was not like that. So it is very important. You may get question from here. So they will give you options of delivery has to be planned at 36 weeks or 35 weeks. What will the choice of treatment? Corticosteroid, magnesium sulfate, both, or like this way they will give you options. So answer will be a course of antenatal corticosteroid and magnesium sulfate. Okay, now so about the PIGF, what the information I like, it is important because when we read this guideline, little things has to be clear, that will make better understanding. So usually it measures this the PIGF test. They measure PIGF levels in blood, in this plasma or serum. Okay, and what is it? It is a sort of a protein that involved in angiogenesis. That is the formation of new blood vessels. So what we already know from our UG days, that when the placental formation occurs, so there are new genesis occurs, and the wall of uterine, like uterine small arteries, they are replaced by trophoblast. So this way new genesis occurs. Okay, so because of new genesis, normally this protein has to be in a higher amount in normal pregnancy. But what happens in the preeclampsia, or if the affection if the preeclampsia is going to happen, then that vascular invasion doesn't happen correctly as the way it should happen. Therefore less angiogenesis occurs, and because of that PIGF level will be abnormally low. Okay, so this is one thing. Usually in normal pregnancy this keeps on rising, and peak occur at 26 to 30 weeks of pregnancy. Okay, but if the placental dysfunction is there, so they will not rise at this level, so peak will not occur. Okay, apart from this, another these tests also measures FM soluble FMS like a tyrosine kinase. Okay, so this is another protein. Okay, this is another kind of protein that is associated with blood vessel formation. So in the women of preeclampsia, levels of this protein, that is the FMS like tyrosine kinase, it will be higher than normal pregnancy. This from SFL LT1 question has already, one SPA I have seen. Okay, it has come in the exam in 2015. This question from this part question has come. Okay, so the thing that you have to remember is that in preeclampsia, PIGF level will be low, and FS SFLT1 level or FMS like tyrosine kinase 1 level, they will be high. Okay, only if you can remember this thing, your SBAs will be solved. Usually it comes as a SBA only, and previously this was there in the talks, but now in this guideline it has come up. So when a patient has a chronic hypertension, so we want to know what is the possibility that this woman will develop preeclampsia. To find out that possibility, we do this testing, PIGF based testing, and it is usually done in between 20 to 35 weeks of pregnancy. Now the things has been clear to you after going through the basics, that why all these testing are done. Okay, is it clear, guys? Is this clear?
Yes, doctor, clear.
Okay. Now coming now the after delivery, so how you will take care of the patient who has postnatal hypertension, postnatal chronic hypertension. So again, what the guidelines say, you have to see them daily for 2 days, then once daily in between day 3 and 5. After that it is clinically indicated. You can just go through once, but I have not seen question from here. But what will be your aim? Our aim is always to keep blood pressure less than 140 and 90. So so this is the aim in the postnatal period. Apart from this, if we have to review the antihypertensive treatment that patient is taking, so it will be done after 2 weeks, 2 weeks after birth, and it can be done either with a GP or specialist. If they are on any kind of methyl dopa, so methyl dopa has to be stopped within 2 days after birth. So you will get question from this part also. Now another question, why we have to stop methyl dopa? Because it will worsen postnatal depression, therefore they want to stop this medication. Apart from this, if the patient of a chronic hypertension is there, so medical review has to be there at 6 to 8 weeks after birth. That will be again with a GP and with a specialist. So from all three lines that I wrote below, all three lines question will come. Okay, so you have to remember this. So antihypertensive, so there should be a review after 2 weeks of birth, Then there will be another medical review after 6 to 8 weeks of birth. And methyl dopa has to be stopped within 2 days of birth. The reason you already know, because it will worsen the postnatal depression. So that's all about the all update about the chronic hypertension from this guideline that I had to say. So now I'll be moving to gestational hypertension. Till now, anyone of you have got any question can ask me. Okay, I think no question. Okay, one important thing I would like to say is that in this guideline, what they say that salt restriction has to be done, but salt restriction will only be required in the patient of chronic hypertension. Okay, in gestational hypertension, in preeclampsia, about the salt restriction, this guideline maintains nothing. Okay, so according to this guideline, salt restriction has to be in the patients of chronic hypertension. Now I'm moving to gestational hypertension. So gestational hypertension, everybody knows gestational hypertension, anything belongs to pregnancy or has come de novo, new in the pregnancy. So if it comes after 20 weeks, but there is no proteinuria, so this will be gestational hypertension. These definitions are important, okay, because sometimes you will find within the small lines you will find a clue from them. So gestational hypertension is the hypertension after 20 weeks of pregnancy with no protein in urine or no proteinuria. Now, a lot of question you will find from this table. So what I have done, I have the part from where the question comes, I have marked them with a yellow color. So you guys have, because it is very difficult to remember all table, but the part from where question comes, that is important. Okay. Now, first you have to find out the classification. Previous guideline, they used to classify as mild, moderate, and severe. Okay, but this has been removed in this guideline. Now they have put patients in two categories. So it is either hypertension or severe hypertension. So if it is less than 160 and 110, okay, just see here. So less than 160 and 110 is hypertension, more than 160 110 is severe hypertension. Just remember this very small thing. So what is the classification is from the 160 110 only. Less than it is hypertension, more than it is the severe hypertension. So this is the only classification that is there in this guideline. So this now, according to my opinion, they have made the thing easy by doing this. Okay, because previously it was too much to remember so many blood pressure ranges. Now what you will do, so this is same as there in the guideline. So if the patient comes to you with a gestational hypertension, now if it is severe, you have to admit this woman. Okay, 160 110 is a severe, so this you have to admit this woman. Below than that, admission is not required. Then if what about treatment? Now we already know that threshold to start any treatment is 140/90. Okay, this we are we know it that once the blood pressure crosses 140/90, then only we have to treat. So treatment is only if it is 140/90. But here blood pressure is so much high, 160 110, we have to treat them all. Okay, and threshold is same. Okay, threshold same, so we will not remember threshold. Now like you will get question from this line, blood pressure measurement. Now we are not admitting this gestational hypertension patient. So what we'll say, okay, once or twice you can go to your GP and get your blood pressure done. So just see, only one or twice in a week we have to see blood pressure. But here patient is admitted and blood pressure is so high. So what you will do, admitted patient until the blood pressure is less than 160 110, we have to see it very quickly as we do in our practice. So we have to see them within every 15 to 30 minutes. Okay, and once we are happy blood pressure has come controlled and it has come less than 160 110, then we can measure, then we'll just ask midwife or nurse that she has to measure blood pressure daily till the patient is admitted. Okay. Now once the patient you discharge, then what will be the frequency? So frequency is this only, once or twice in a week. Why? Because she will be once discharged, she'll be going to community. So in community, or she will be on the other side on the day outpatient treatment. So she that time only once or twice measurement of blood pressure is fine. Okay. Now blood test. Whenever patient with hypertension comes to you, at least do her blood test. So we do 3 blood tests. These are basic tests. We do full blood count, we do liver function test, and we do renal function test. So these are these are the tests done. So once the patient has come, so we'll do them. Okay. After that, every week we can see them. Every week. Okay. So this part is same, but still you have to know. And PGIF testing in all gestational hypertension patient we are doing. Why? We are worried. Preeclampsia can happen anytime. Coming to fetal assessment. So the important part, like every time when the patient will come, you will just auscultate fetal heart. That we do regularly. Apart from this, we have to do the when the diagnosis of the hypertension is there, immediately we'll do one ultrasound. After that, we have to repeat what will be the frequency. So frequency changes there. So if it is a less than 160, 110, we can say, okay, you can get it done every 2 to 4 weeks. But this patient 160, 110, any time we have to take some decision. So we have to repeat it at least 2 weekly. Okay, CTG is at the diagnosis and when it is required. So this is just sum up, and you will get question from here. So they will give you a scenario patient with this much weeks of pregnancy with this hypertension. So what will be the treatment options? So you have to find it out. The option will be, okay, offer admission and blood test weekly, and ultrasound 2 to 4 weekly. So you will get an option that will be combination of this. So the part I have colored yellow, these are the different, or rest all other whatever they have written, everything is same in both kind of them. So I would do the sum up again. So in severe hypertension more than 160, 110, we will admit this patient, we will offer treatment, we'll do blood pressure measurement every 15 to 30 minutes, and once they stabilize, we'll do her daily. We'll measure blood full blood count, liver function test, kidney function test at the time of presentation. Then we do repeat them weekly. And also at the time when the patient has come, we'll do CTG and fetal heart monitoring and ultrasound. But ultrasound has to be repeated in severe hypertension twice, every 2 weeks. So this is the summary of the gestational hypertension treatment, what they want. And basically I have made the same kind of presentation in the table as it is there, same in the guideline, because that carries a visual impression. But what I did, I highlighted the points of what is different, and also from where you will get, these are the points where you will get question from. Is it clear about that gestational hypertension?
Yes, doctor.
Now again, in the gestational hypertension also, we are worried that any day if this woman any day this woman can have preeclampsia. Therefore we will do the same type of testing what we have discussed. So it is done from 20 weeks to 35 weeks of pregnancy. Okay. And treatment, again, it is exact same as chronic hypertension. Just remember, it is levotalol, same hierarchy. Okay. Levotalol, nifedipine, methyl dopa. Just remember that. Then time of birth, it is also exact same as with the chronic hypertension. So it should not be planned before 37 weeks. Okay, it should not be done before 37 weeks. But if 37 weeks are passed and the blood pressure is lower than 160, 110, then there should be agreement between the patient and doctor. If the delivery is early, then the course of steroids and magnesium sulfate has to be given. So this part is same. Now coming to the postnatal gestational hypertension. So sometime what happens that during postnatal period, so the we will measure the blood pressure, and if we think that blood pressure is already 180 30, so we will reduce it. Okay, and if it is rising, it is 150 100, and this patient was not on any treatment, so we'll start it. So this threshold we have to remember. Then methyl dopa, again it is same for methyl dopa. Methyl dopa has to be stopped within 2 days of birth, and 2 weeks. If the gestational hypertension patient, they are taking medication, they are on antihypertensive treatment, then medical review at 2 weeks, and again medical review at 6 to 8 weeks. Okay, so this is almost same as chronic hypertension, but here they want to reduce hypertensive, the thresholds are different. So they want to reduce antihypertensive if the blood pressure is below 180 130 and 80, and we have to start. Okay, we can start also if it is more than 150 and 100. Now that's all about the sum up of the gestational hypertension of from the NICE guideline. Any one of you have got any question? Okay. Now the preeclampsia part. So preeclampsia part of guideline. Now this is from strategy. Okay. So in the so in the strategy, this was the classification given. Therefore, I kept the same classification here. So according to the International Society for the Study of Hypertension in Pregnancy, so what they say that preeclampsia is the gestational hypertension that has got that can occur, that occurs at or after 20 weeks of pregnancy with new onset all these condition. Till now, what up to my knowledge also, what we knew that it is the gestational hypertension after 20 weeks of pregnancy with proteinuria. But this knowledge or this classification is from strategy. Now what they are saying, gestational hypertension after 20 weeks. So these are the added criteria. Proteinuria we already knew. Now other criteria they have added. Other maternal organ dysfunction. So what could be they? Acute kidney injury. Okay. So creatinine is more than 90 micromole, and liver involvement, that is elevated transaminases is there more than 40, or a right upper with or without right upper quadrant pain, or like epigastric pain, any neurological complications. Okay, and that is altered mental state, blindness, stroke, clonus, severe headache, persistent visual scotoma, and hematological complications, thrombocytopenia. So what they are saying, like if these are these maternal organ dysfunction are also there, then also it will come under preeclampsia. Third, what they wrote is uteroplacental dysfunction, like any IUGR, any abnormal Doppler waveform, or stillbirth. So that will also be coming under preeclampsia. So this is new change, and I have not changed even a single word from the strategy. So this much they wrote. So this you should know. Maybe they will ask somewhere in the exam. Okay, is it clear? Now, this is the pathophysiology. Just in recap, we are reading it from our UG days. What happens? So this is the blood vessel. So what happens in the normal pregnancy? So the blood vessel do have a smooth muscle, Okay, so there will be a disruption of vascular smooth muscles. Normally, there will be endothelial cells will be replaced by endovascular or extravascular trophoblasts. These are endovascular or extravascular trophoblasts. So as the muscle has gone, so there will be loss of vasocontractility that will cause dilatation of spiral arteries. So if the spiral arteries are dilated, so there will be enough blood flow in the intravillous space for that is required for the uteroplacental functioning. Okay, so this happens, this we are reading it from our UG days, and this type of thing usually happens in normal pregnancy. But what happens here in preeclampsia, so there is failure of endovascular um, invasion by trophoblast. So there will be a retention of contractility. So there will be insufficient and blood will flow to the intravillous space. Therefore there will be inadequate uteroplacental perfusion. So because of that, there will be lack of proper maternal or fetal exchange that occurs. Nobody is going to ask the question from this slide in part 2 and part 3, but just in updating or revising the previous concept that we used to read, why what is the pathophysiology of preeclampsia. Now because of this particular situation, all this will happen. So there is a defective extravillous trophoblast invasion. Because of that, there will be hypertension, there will be liver involvement, so we know HELP syndrome. There will be kidney involvement, therefore we see renal dysfunction or proteinuria. So from here we are getting proteinuria, from here we are getting hypertension. Okay, and again if there is a brain involvement, so there will be edema, headache, seizures, so many things will happen. Okay, now this is also important that what are the risk factor that for preeclampsia we do risk assessment. So what are the preeclampsia is more common in primi gravida. Okay, you will find SBA from this slide. So and risk increases with increasing in the interval between pregnancies. Okay, apart from this there are other risk factor. More than 40 years of age, any woman, previous history of preeclampsia, pre-pregnancy obesity, and donor egg or embryo donation or donor insemination. Okay, that also causes is sort of a risk factor for preeclampsia. Apart from this, diabetes, pre-existing hypertension, family history of preeclampsia, and any medical disorder for example antiphospholipid antibody syndrome. This we already know, and you can get SBA from here, but sometime they will give all these factors together, and they will give all up like which is least associated, or sometimes they will ask the question what is most commonly associated. So in that particular situation, what we have to find out, we have to find out RR ratio or relative risk ratio. Now I have pointed it. So highest RR ratio is 9.72, and it is with antiphospholipid antibody syndrome. So you will say preeclampsia is if it is the highest association, and they have given some option, so this would be the answer. Next high is the previous pregnancy, previous history of preeclampsia. So many RR values nobody can remember, and no need also. Okay, and third number is diabetes. Okay, third number is diabetes. So if any such kind of question is coming, so you have to know which condition will have greater association with preeclampsia. Okay, I have seen this kind of question has come once. Okay, now what we get, there had been any exam without this without this risk assessment. So this is really important to remember for part 2 people also and part 3 people also, because part 2 people there will be direct SBA or EMQ. For part 3 people, usually in many of the scenarios, they have to find out the like what are the risk factor, and according to that they have to start aspirin from the 12 weeks of pregnancy until birth. And again, as like you have to, part 3 people has to bring this aspirin if it is required in their questions, because it is too much favorite for RCOG. So this table as it is has to be by heart, everyone who is giving this exam. So what is a now? So what they have done, they have given some risk factor. So so if any of this risk factor is there, so if only with the one risk factor, aspirin has to be started. But from the lower part of this, two of this has to be present, two factor of this has to be present, two moderate risk factors are present, then only aspirin will be started. So you will find a lot of question with this, and this table everyone has to remember. So what is the one risk factor? Women with at high risk, like hypertensive disease in previous pregnancy, chronic kidney disease, autoimmune disease, SLE and APS, type 1 and type 2 diabetes, and chronic hypertension. Okay, so these are the risk factors, and these were present previously also, but this chronic hypertension they have added in this guideline. Okay, so if you find in your question any this kind of factor is there, so you have to, with the only one factor, aspirin has to be started from 75 to 150 milligram from 12 weeks of pregnancy until the birth of baby. But another type of scenario, if you find two factor from here, like first primigravida, first pregnancy, age more than 40, pregnancy interval more than 10, BMI more than 35. Okay, BMI more than 35. People are too much, make a mistake here. So just I want to tell you, like for PIH or preeclampsia, BMI is 35, that we consider it as a risk factor, and for GDM screening, BMI is 30. People get confused with that, so please remember it. Then, and family history of preeclampsia. Now in this part there will be personal history of preeclampsia here, but in this part it is family history of preeclampsia. This part also people get confused, and twin pregnancy or multiple pregnancy. Fine. So if you find in your scenario that two risk factor from here, it is there, two risk factor are present, then you have to start aspirin 75 to 150 milligram from 12 weeks of pregnancy until the birth of baby. So this table has to be by heart for both part 2 and part 3 people. Now what are the complications can happen, though we know it? So what could be the fetal complication is IUGR, preterm delivery because the blood pressure shoots up, and IUD. Okay, and what could be the maternal complication? We already know. It could be eclampsia, it could be pulmonary edema, HELP syndrome, intracranial hemorrhage, retinal detachment, and death. Okay, so this maybe you get somewhere some SBA from here. This is from like not from guideline, from strategy. Now another important question, they will give you a scenario, the blood pressure will be high. So in the whole scenario, after that they will ask what is the next step. So your answer will be protein quantification. Okay, so usually in many questions you will find only protein quantification will be the answer. So protein quantification, how it is done. So it is important, and there has been update in this guideline. So usually what they recommend, this automatic urine dipstick will be can be used. So this will be the choice. So if the dipstick is there, then if it is 1 plus or more, if it is 1 plus or more, then they will consider it as a protein urea. On the other side, they can apart from this, two other ratios can be done for the protein quantification. Here they are not doing any quantification. Here only they will find out whether proteins are there or not. For the quantification, there are two methods. Either they will create protein creatinine ratio. So this was there in the last guideline also. Now in this new guideline they have put this also, that is albumin creatinine ratio. Okay, so this is an update from the last guideline. You guys may get any question from here. Now, if you have to see protein creatinine ratio, then what is the threshold? It is 30 milligram mmol. Okay, if it is 30 milligram mmol or high, then it will be like they will consider this as a significant proteinuria. Okay, so you will find this. You guys have to remember, because sometime in the exam, in the questions, they will not say protein positive or dipstick positive. They will give some value of protein urine creatinine. Like for example, I'll just tell you, if they gave hypertension with the protein 35 or 55, then it will be like the preeclampsia. And but if they say hypertension and they say protein creatinine ratio is 20, in that particular scenario, it will be gestational hypertension, because proteins are low for quantification. So sometimes people, if they don't know this number, they don't remember this number, so they are going to make mistake. So it is worthwhile remembering this number. Okay, remember this. Now in this new guideline, albumin creatinine ratio also has come. Okay, and the threshold is 8 milligram mmol. So you have to remember this number also, because if now the new questions will be coming, so maybe in your exam they will not give protein creatinine ratio, they will give albumin creatinine ratio. Okay, so this both of the things you have to remember the number, because sometimes this will require in the exam. Now once the blood pressure is done, after blood pressure, you have done the quantification of protein also. Now how you will find out clinically, what will be the assessment. So everything is from the guideline. So systolic blood pressure is like 150, sustained blood pressure it will be 150 160 or higher. So, and they have done some biochemical criteria also. Rise in creatinine more than 90 micromole or above, or rise in alanine transaminase over 70 international unit, or thrombocytopenia less than 1.5 lakhs, and sign of impending eclampsia, signs of impending pulmonary edema, signs of severe preeclampsia and suspected compromise. Okay, so these are this is for the assessment. Now for this, now right now we have just read about PIGF testing. So this PIGF testing was to assess whether the preeclampsia will happen or not. And we used to do this in the patients of chronic hypertension and gestational hypertension. Now something new has come for in the preeclampsia. In preeclampsia, what has come new is the PIERS scale, or this PrEP-S scale. Okay, so these are certain risk prediction models. So they will predict the risk, how much complication can happen. So appropriately, patient can be transferred from one hospital to another hospital, or in utero transfer can be done. Okay, I'll just explain about this also. So PIRS can be used at any time during pregnancy, and PrEP-S is again a risk assessment model or risk prediction model. This will be used only up to 34 weeks of pregnancy. Okay, and both of these models, they are not predicting any outcome for the baby. For example, baby will be small, baby will be IUGR, or what will be the condition of baby at birth. No, they are not producing that. So this is new in this guideline, so you guys may get question from here as well. Okay, so I will just show this risk prediction models, because if you see them visually, then it will cause more impact. So this is PrEP-S model, like these are the again it is from the internet only, okay. So these are the these are the points they will look into this model, and there are certain grading or categories are there. According to that, they will assess. So they will do all these points, and with that they will do some risk score calculation. With that score calculation, they will be able to find out whether there is a complication, like risk of complication in early onset preeclampsia is there or not. So this was prep as model, and this prep as model can be used till 37 weeks or 34 weeks of pregnancy. Okay, so this is a prep as model. Another, what they have said is full PIERS model. Okay, this is preeclampsia integrated estimated risk. So these are the few things they are checking there. Okay, apart from, like, I have taken some part of it. It was very big paper, so just to give you visual impression. So they will do the integrated assessment of risk. Apart from this, some validation score will come, and with this score they will be able to find out the outcome. Okay, it is, nobody is going to ask this much information from you guys in the exam. This is just for your better understanding and the visual impression. What you have to remember is this part only, that a full PIERS or PrEP-S model, these are the risk assessment model. They help to find out, to assess the risk. So appropriate decision can be taken if any requirement for in utero transfer is required. And full PIERS model, it can be used at any time in pregnancy, but PrEP-S can be used till only 34 weeks of pregnancy, and none of these models, they cannot predict any baby outcome. Okay, so this is important to understand, because all these they have put in this new guideline. They were never, all these were not present ever before. Okay, so is the thing clear about this? Any question? Okay, now similarly, now the assessment has been done, risk assessment has been done. So now we come to treatment. So pre-eclampsia treatment. Now, so it is almost same kind of presentation is there in the guideline. So again, I have not changed it. Only I have done some color coding that are different in both of these. So again, they have, it is a very good, like only two categorization of hypertension: severe and hypertension. Mild, moderate they have removed, so that they have done very nice thing. So if it is less than 160, it is hypertension. If it is more than 160 and 110, it is severe hypertension. Okay, now basically, all patients of preeclampsia we do admit, okay, and treat them, like, but here, if any, in the hypertension column of it, if the risk assessment model has been done, and risk assessment shows that they are at high risk, or if any clinical concern is there, then they will be admitting. But if some patient is sort of a very stable patient, only blood pressure is more than 150/90, maybe that preeclampsia patient they will not admit. So this is different from the previous guideline. Okay, previously there are three categorization and they used to admit all, but now they have put some criteria, so this part is different. Now threshold we are not checking, because it is always same. Okay, we want blood pressure to be at this limit. Now blood pressure measurement, so this kind less severe patient, we would like to see them every 48 hours. Every 2 days we have to see their blood pressure. But if this patient are admitted in the hospital, then of course if the admitted patient are there, we have to see them more frequently, but that frequency they have not measured. And this part is the same for severe hypertension. Till the patient is stabilized, we see them every 15 to 30 minutes. After that, if the patient is admitted, we can see 4 times daily. Why we are seeing 4 times daily? Because this is, they have got severely hypertension, or blood pressure was more than 160/100. Okay, so this part you will get question from. Okay, Then proteinuria, usually are already diagnosed, they have got proteinuria, but if another repeat usually not required because the diagnosis has already been done, but if any clinical situation demands it, then it can be repeated if the clinical condition is there. Then this part you will get lot of questions. So blood test, we already know what type of blood test we do: full blood count, kidney function test, renal and liver function test. In here in this column we are doing it 2 times, like 2 times in a week. Here we are doing 3 times in a week. From this line you will find a lot of number of questions come from this line only. Apart from this, fetal assessment is same. So when the patient comes to us, you'll do fetal heart auscultation, you'll do CTG at the diagnosis, okay? And whether it is repeat, it will depend upon the situation. Then USG has to be done, and but repeat USG frequency will be 2 weekly, because this is pre-eclampsia, so it can worsen very fast. So every 2 weeks we will do USG. So this part is same, okay? So this is the like sum of pre-eclampsia management, and I try to put same way it was there in the guidelines, so the visual memory becomes very like important while answering question. So in sum up, severe hypertension, will admit all patient, will treat them, will measure the blood pressure every 15 minute to 30 minutes till the blood pressure is under our control, less than 160, 110. After that, patient is admitted, so we would like to measure it every like 4 times in a day. Now blood test will do 3 times in a week, okay? Apart from this, we would like to check baby at the time of diagnosis. So ultrasound stem, that time we'll check fetal heart. Apart from the CTG will be done, and ultrasound scan will be done, and the frequency at which the ultrasound scan will be repeated will be every 2 weeks, okay? So this is the sum up for pre-eclampsia management. Now timing of birth. So timing of birth, like it will be usually we want everyone, like whatever will be the type of hypertension, what we are seeing till now, they want to deliver them after 37 weeks of pregnancy. Everybody knows why, because to avoid complications of preterm. But some problem can happen, and you have to deliver them before 37 weeks of pregnancy. So what are that factors? If the blood pressure is not under control, despite they have used even 3 types of drugs, okay, blood pressure is not coming down, then maternal oxygen is falling down 90%, okay? Now there are too much of problem with the liver function test, kidney function test, hemolysis, platelet count is going down, or neurological features like severe intractable headache or repeated visual scotoma, so or eclampsia. So these are the conditions where we will think that yeah, we should deliver this baby early. And placental abruption, but placental abruption will be an emergency. And when the fetal Doppler is done, so anytime it is reversed end-diastolic flow, so you have to consider admission, sorry, for this delivery of the patient. So in that, but because if you continue with the pregnancy, it will have a stillbirth. The pregnancy will end up in a stillbirth. So this, though we already know all this, but still you have to remember, because they will give some scenario in your question and they will put one of them, okay? Maybe they will say, oh, patient has got a history of preeclampsia, scan shows that baby is small, or IUGR is there, but we have done a but pulse oxygen saturation is not picking, it is less than 90, okay? Maybe they will give you this kind of scenario. What will be the answer? The answer will be preterm delivery, okay? So early delivery before 37 weeks. So this part you already know, but yeah, again we have to revise. Or any time in any kind of hypertension, if we are offering delivery less than 37 weeks, or like please give magnesium sulfate and please give steroids. Okay, so this is same for every hypertension. Basically, what appears that new guideline has become better than older one. So now coming to blood pressure assessment. So coming to blood pressure assessment in the like postnatal period. So usually till the patient is inside your hospital, if the patient is not has not taken any treatment, till the patient is admitted with you, see 4 times a day. After that, you what the guidelines say, you can see them once, one between 3 to 5 days, then on alternate days until it becomes normal. And similar kind of thing they have said, if the patient is on hypertensive, if she is admitted, we can see her more frequently, so we'll go to see blood pressure 4 times a day, but later on it can be every 1 to 2 days or alternate day. Usually I have not seen question from this part of the guideline, but yeah, we have to do it. And all red part what I have put here, from every part question comes. Okay, so this you have to like remember. So if the patient of preeclampsia, if the patient of preeclampsia on the antihypertensive treatment, at 2 weeks there will be review, then there will be medical review again at 6 to 8 weeks. Then 6 to 8 weeks they usually do the protein urea test. So if at 6 to 8 weeks protein urea is there and they are still on the treatment, then at 3 months there will be kidney function test. Okay, so they will so it will be with a GP and a specialist. So there will be again 3 months after birth, because kidney function is done. Now if the abnormal kidney, if you find any woman has got abnormal kidney function test, then they should be referred for the specialist kidney assessment. So this part of this part of slide, you will find a number of questions like EMQ usually comes like when she has to see this patient. So I'm repeating it again. So this woman will require, if she's on the antihypertensive treatment, review at GP and specialist at 2 weeks. Then there will be medical review at 6 to 8 weeks. At 6 to 8 weeks, they usually do the urine for protein also. If the protein urea is 1+ and the patient is still on medication, then again review at 3 months. And at 3 months, they will be assessing kidney function test. Okay. And if the kidney function test shows abnormality, then it will be referred to the kidney specialist for the kidney specialist assessment. So this part of the guideline where I have marked it, like that you have to know, because questions come from all these lines. Questions usually come. Now fetal monitoring. So fetal monitoring, we have divided the hypertension in 3 parts. Similar way it is the fetal monitoring. So now chronic hypertension. Chronic hypertension, it will be uterine artery Doppler at 28, 32 and 36 weeks. Okay, 28, 32 and 36 weeks. In gestational hypertension, they will do at the time of diagnosis, there will be like umbilical artery Doppler, then repeat has to be done in every 2 to 4 weeks. But on the other side, if it is severe gestational hypertension, or if any pre-eclampsia, so we have to do this Doppler every 2 weeks. So you will get question from all red lines. Okay, so I'm repeating it again. In chronic hypertension, we have to do umbilical artery Doppler at 28, 32 and 36 weeks. In gestational hypertension, it should be every 2 to 4 weeks repeat. And in preeclampsia and in other cases of severe gestational hypertension, okay, just remember this is gestational hypertension but severe, so assessment has to be more. We have to do the umbilical Doppler assessment every 2 weeks. Okay, so this is, I have put them in a table, therefore the memory becomes easy. So there will be no confusion in the exam, otherwise it creates too much of confusion where it was 2 weekly, where it was 2 to 4 weekly. Okay, so chronic hypertension is totally different. Gestational is 2 to 4 weekly. Rest all hypertension, these are high, preeclampsia and severe, it will be every 2 weeks. Okay, so you can, this would be the way to remember it. Now you will find a number of questions from this slide. This you have to remember by heart. And like what I just discussed in a table form, it was the routine monitoring, but there will be some patients that require our additional monitoring or additional care. So in these patients, one time Doppler will be done at 28 to 30 weeks, but it will usually depends upon the previous pregnancy event. So if the previous pregnancy event had occurred earlier than 28 weeks, then this Doppler will be done before, earlier also, and repeat has to be every 4 weeks. So if from this line you will get a number of questions. So what are these criteria of previous pregnancy? So these all are the criteria of previous pregnancy, like severe preeclampsia in last pregnancy, preeclampsia resulted preterm birth, and IUGR baby, IUD, placental abruption. So if all this happens in previous pregnancy, so we'll be very careful in this pregnancy. So there will be Doppler at 28 to 30 weeks, and this pregnancy will repeat it every 4 weekly. So this frequency of repeat, and also what can happen in previous pregnancy. Therefore this much 4 weekly repeat of Doppler scan is there. So that this part, that what I have colored and what are the indications, that has to be read very nicely, because you will find question from there. Now till here, till the fetal monitoring part of it, any one of you have got any question? Okay, no question. Now coming to intrapartum, if the patient like what you will do, uh, if any patient of hypertension is there, you have to keep eye on the blood pressure, and you have to see every week, every hour. Okay, every 1 hour your blood pressure has to be monitored. But if the blood pressure is very high, you will see again every 15 to 30 minutes till it is less than 160, 110. Okay, apart from this, whatever the medication this woman is taking, it has to be continued during labor, because labor again is a stressful condition. And if the woman does not take her previous medication what she was taking, then her blood pressure is likely to be shoot down during pregnancy, during labor. Apart from this, as we already know that in the preeclampsia there is less risk of pulmonary edema. So we keep the if we have to offer for any indication IV fluid, so it has to be, we have to keep liver on a dry side. Fluids has to be restricted to 80 ml per hour. Why? Because we are worried about the complication of pulmonary edema. Okay, so whenever we are giving epidural to patient, usually loading is done. Okay, usually like we load them. We see this is our usual hospital practice. But if the patient has preeclampsia, then that preloading is not required, and fluid has to be at 80 ml per hour. Now, if blood pressure shoots up, then you can offer operative or assisted birth in the second stage of labor. Okay, so this is the sum up of the intrapartum care that has to be required for the women of preeclampsia. So now, the magnesium sulfate, it is really important for part 2 and part 3 people. Now, how this has become for part 3 people? Because I have heard one time this teaching station about magnesium sulfate has come. So and you have to read it very well. And for part 2 people, every part of it can be asked as a question. Okay, so what is the magnesium sulfate? So magnesium sulfate actually will do with the regimen That is the usually they are giving it within IV regimen. Okay, so they're not giving lighty cocktail or pit chart. What is followed as a regime of magnesium sulfate in other places of the world, but in UK they're not, they're not following that pit chart or lighty cocktail. In UK they follow, they called is a collaborative trial. I am not able to remember that name, but it's some collaborative trial. And so be very careful. The UK, what they follow treatment is different for doses and treatment. These are different for the magnesium sulfate. What we used to give, okay. So in this protocol of magnesium sulfate, or whatever the magnesium sulfate they are giving, it is with the intravenous route only, okay. So usually loading dose has to be given. So what is loading dose? 4 gram intravenously over 5 to 15 minutes of time. Okay, so you have to remember this. Now you have to give maintenance dose. Maintenance dose will be 1 gram per hour. Okay, and it has to be continued 24 hours after the last fit. So now you will, so this is the loading dose, you have to remember this. And maintenance dose, this also has to be remembered. Now they will give us a certain question that patient was on magnesium sulfate, again she throw a fit. What will be the answer? What you have to do, you have to further administer magnesium sulfate. That can be given 2 to 4 gram intravenously over the period of 5 to 15 minutes. Okay, so from these parts, you will find questions, okay, and you have to know this. So this is the regime they are following there. Now whenever the magnesium sulfate is given, they say that it has to be given in the critical care setting because monitoring is required. And usually it is offered to the patient if the delivery is planned within 24 hours. Okay, so then in severe preeclampsia patient, you think that, yeah, I had to deliver this patient, so 24 hours before, please give magnesium sulfate. Now magnesium sulfate, uh, like consider what they say, consider magnesium sulfate if one or more following pre-eclampsia features are present. Like if it is a severe hypertension, we are offering magnesium sulfate. But if it is not the severe hypertension, then there has to be one factor. What will be the one factor? Either it is severe headache, or it is visual scotomata, or nausea, vomiting, epigastric pain, or oliguria, or progressive deterioration of any of blood test. So in this particular situation, if one or more factor is present, okay, if more than one factor is present in any patient, then क्या कहते हैं, then magnesium sulfate has to be given. Okay, so there has to be two factors before we consider magnesium sulfate. So this is from the NICE guideline. So it is same as it is they have written. So what you have to remember is, you have to remember loading dose of magnesium sulfate. You have to remember that is 4 grams intravenously over 5 to 15 minutes time, or this should be followed by maintenance dose 1 gram per hour for 24 hours or 24 hours after last fit. If this patient has another fit, further dose of 2 to 4 gram given intravenously over 5 to 15 minutes of time. It has to be given in the critical care settings. And if two of these factors are present, then again you have to offer magnesium sulfate. Now what are the if the severe hypertension is there, and what will be the choice of antihypertensives? So number one is labetalol. It is always labetalol. So either it can be given orally or IV intravenous, or second line will be second, it could be oral nifedipine. Last will be IV hydralazine. Many of the stations, many of the stations, or many of the this thing question, you will find that a patient has got an asthma, that time you can't offer them labetalol. So if in severe hypertension, you have to use second choice, that will be IV hydrolazine. Now in whole hypertension guideline, only one time fluid overloading is done. That is before the first dose of intravenous hydrolazine, they do a loading of the crystalloid up to 500 ml is done. Okay, like in all other conditions, they usually in pre-eclampsia patient there is a fluid restriction because of the fear of pulmonary hypertension. But giving hydrolazine, giving crystalloid 500 ml as a loading fluid before, it is the only one condition where you are giving preloading fluids. Okay, now this part of the guideline has changed about the breastfeeding thing. Now what they are saying, if the patient is on breastfeeding, so then some of the drugs they may pass to the baby also. So they should be, advised, or they should be given these warning signs. If a baby has got drowsiness, lethargy, pallor, cold peripheries, or poor feeding, then they have to report to the hospital. Okay, this is one thing. Another thing, what in the postnatal period, what should be the treatment of choice? So what they are saying, it is enalapril. So this is a change from the previous guideline. So what they are saying, enalapril has to be offered with appropriate monitoring of maternal kidney function or renal function and maternal serum potassium. So previously it was not the choice, but this guideline they have changed it. So enalapril in the during the period of breastfeeding, a time with the appropriate monitoring of maternal kidney and serum potassium. Now this again they have added new in this guideline. If you find a patient from African or Caribbean family origin, then treatment of choice will be amlodipine or nifedipine. Okay, so these are two things are there for all other patients. Drug of choice during postnatal period is enalapril, but if a woman belongs to African or Black African or Caribbean family, then it will be nifedipine or amlodipine. So as this part has been added new in this guideline, then maybe when the people, you guys are giving exam, so you will find that in the question, maybe they will tell that patient from Africa has come, or African family origin, and she has got this. What will be the choice of like postnatal antihypertensive? So you will say for nifedipine and amlodipine. So this is a new change in the guideline. You have to remember. Now they are giving only one medication, that is enalapril. So patient comes and the blood pressure is not getting controlled with enalapril. So what you will do? So you will add either nifedipine or amlodipine. Okay, but any of this medication is not tolerated or it is ineffective, then consideration for atenolol or labetalol can be done. Okay, so now I'm repeating everything again. So drug of choice is enalapril in the postnatal period. Now, if the woman of a Black African and Caribbean family, then the drug of choice in postnatal period will be amlodipine and or nifedipine. So these are the drug of choices. But if the blood pressure is not getting controlled with one medication, you can add another medication, that will be amlodipine or nifedipine or enalapril. So this combination can be given, and if this combination is not working, another line you can think of atenolol or labetalol. But be very careful, any diuretic or any angiotensin receptor blocker, these are avoided in pregnancy. So all diuretics or angiotensin receptor blockers are avoided in pregnancy. Okay, this is the new update in this guideline. It was not there previously in the guideline. So this part of the guideline becomes important to us. For part 2, there will be direct question. For part 3, patient, you have to explain that what type of medication she would require once baby is delivered. So this part you have to remember. Okay, so this is also important, and the question comes usually from here, but it's a big table, and remembering all this part of the table will become difficult for everyone. But where lies the question? Usually question comes from this part. Okay, so I have color coded it. So now I will read only this part only. If preeclampsia is there, if a patient has preeclampsia in this pregnancy, what will happen in her future pregnancy? So it will be 1 in 7 or 14%. Any hypertension can happen. Okay, but you have to basically remember this part. So preeclampsia in this pregnancy, what are the chances of preeclampsia in subsequent pregnancy? So it is 16% or 1 in 6. This is overall. But if they say delivery had happened less than 34 weeks of pregnancy, so it will be 33%, okay, or 1 in 3. This part you will get question, okay. This is the main hub line of the question. And if the delivery happens after 34 weeks till 37 weeks, then it is easy to remember. It is 23% or 1 in 4 or 1 in 4. These percentages you have to remember. Rest all other percentages, if you are not able to remember, then also it is fine, because it will be very hard how much number you can remember, but you can't go in the exam without remembering it. So preeclampsia in this pregnancy, risk of preeclampsia in another pregnancy is 16% or 1 in 6. If they deliver in between this timeline, 28 to 34 weeks of pregnancy, then it is 33% or 1 in 3. If delivery occurs after 34 weeks, then chances of coming it back will be 23% or 1 in 4. Just remember this number. So, because the question comes from here only. So this is the hub of it. Okay. So anyone of you have got any question can ask me before I just tell about eclampsia. So any one of you have got any question? Okay. So coming to.
Sorry, Dr. Priyata.
Yes.
I want to ask first line during pregnancy labetalol. If asthmatic patient, we use nifedipine, correct?
Yes, and last will be methyl dopa.
Yes. Postpartum, first line enalapril.
Yes.
Yes. If patient, I will use nifedipine or amlodipine.
Yes.
If combination not tolerate for patient, I will use labetalol. Last option.
Thank you so much. Both. Yeah. Okay, now the eclampsia, it is, you have to remember this, the management of eclampsia, because the questions come from here, so the understanding is required. Apart from this, for part 3 people, you have to remember everything by heart, because it can come as an obstetric emergency viva. Okay, so this is really important. So what is the management for eclampsia? You already know eclampsia is an obstetric emergency. So what you will do, the treatment usually start for all, emergencies treatment patients. We are starting treatment with ABC approach. So first A is airway. Now, what are the points? We have to secure airway. We have to position the patient in the recovery position or left lateral position. Now, why we are doing this? Because we want to avoid suffocation by tongue falling backwards, or aspiration of any vomit or saliva. Okay. Third, we will secure bed, because this patient will fall out, and if that possibility is not there, then nurse this patient or treat this patient on floor. Okay, so this is for A, airway. Secure airway, maintain the position of patient in recovery position or left lateral. Third, secure the bed, secure the bed so that patient will not fall. So this is in points that will come in A for airway. Second will be B for breathing. So what you need to do, you need to give them high flow oxygen, 15 liters per minute. You need to make it ensure that the patient is breathing spontaneously once her fit subsides. Okay, you have to make it sure that she's breathing. If she's not breathing, then you have to start with manual ventilation. Fine. Then comes to C. C is circulation, and again complete call for help. If the all people are not there, then you have to make it sure that you have to call for help. Okay, so you have to secure an IV access as early as possible or as safely as possible. Then a record of pulse, blood pressure, oxygen saturation has to be done every 5 minutes for 30 minutes. And if the pulse is absent, what you will do, please start CPR. Please call anesthesia team. Okay, I will not speak about CPR here because collapse is your new guideline, so you know the steps, and all these steps are not required in this answer also. Here I have put the answer same as it is required point wise for part 3 people. Okay, as an obstetric emergency viva. Therefore I have not wrote any other point that is not required. Then make it sure that you call for help your consultant obstetrician, anesthetist, pediatric team, house officers has come. You need to inform theater and blood bank. You may need help of hematologist also. Call laboratory for urgent results. Okay, so this will be the hierarchy of the treatment for eclampsia. Now after this has been done, so you need to do, you have to control seizures. So how the control of seizures is done? In control of seizures is done by magnesium sulfate, that is a drug of choice. Intravenous route is preferred, that we already know. And again in the UK they are giving intravenous, so it has to be continued 24 hours last seizure. So again, loading dose and maintenance dose. So loading dose is same, 4 gram of magnesium sulfate, but here you can see there is a difference. Here they are giving it only over 5 minutes of time. But when we were doing it in a severe hypertension, that time we were giving this medication in slowly, and we were giving it till 5 to 15 minutes of time. Okay, so therefore this is the one difference here. And usually it has to be if it is given by the infusion pump, then it is good. Okay, so this will be the loading dose. So only one difference is there from the regimen what we saw in the severe hypertension. Coming to maintenance dose is same. It is 1 gram per hour intravenous infusion maintained for 24 hours after last seizure. And if the seizure recurs, or if any recurrent seizure is there, then the bolus of 2 to 4 gram magnesium sulfate over 5 minute time has to be done. Okay, and in that particular situation, infusion rate can be increased till 1.5 to 2 gram per hour. In all like previously we were giving infuser at 1 gram per hour, but as the recurrent seizure has occurred, so we will increase this infusion rate also. Okay, so we are increasing this infusion rate from 1.5 to 2 gram per hour. So the little difference is there from previous, like when we offered this statement in the severe hypertension. Okay, and all this knowledge and all the doses are from third edition of the basic practical skill book. Okay, so like I have not taken this any doses from anywhere else, because that is the book. Basic practical skill course is done by the RCOG, so all doses are from there only. Apart from this, if the magnesium sulfate you are giving, so monitoring is required. So what will be the monitoring? Every 10 minutes for first hour, then it will be increased by every 15 to 30 minutes. What type of monitoring? Respiratory rate, oxygen saturation, pulse and blood pressure. And if the facility for pulse oximeter is there, so it will be done continuous monitoring has to be done, and patient has to be catheterized so that hourly urine output can be measured. Patellar reflexes has to be checked. So therapeutic range for the magnesium sulfate is 2 to 4 millimole per liter. Okay, so this type of monitoring is done. Now, what are the indications to stop magnesium sulfate? If there had been less urine output, less than 100 ml in last 4 hours, or if patellar reflexes are absent. If respiratory rate becomes less, that is 14 breaths per minute, and if oxygen saturation is less than 90, these are the indications. If these are there, you have to stop this magnesium sulfate. And what will be the antidote? Antidote everybody knows. It is 10% calcium gluconate, 10 ml intravenously, that is given over 10 minutes time. Every part of this is real important. Like part 2 people will get question, and part 3 they have to remember it by heart. Now for the control of blood pressure, now after magnesium sulfate you have to control this blood pressure. So blood pressure control has to be, so first line it will be labetalol only. So labetalol, what they say, 50 milligram IV bolus slowly over 1 minute time. This will be followed by infusion, that will be 20 milligram per hour. Okay, and if this response is not achieved, then every 30-minute infusion rate will be doubled, but the maximum dose will be 160 milligram per hour. Okay, so and these doses also you guys have to remember, because when the same station comes in the course. So in preeclampsia management, they want all doses, and also they want every drug, what is the route monitoring, what is required, because it is very basic thing, so they want you guys to know everything by heart. Okay, apart from this, if now again your patient has got labetalol is not available, or your patient has asthma, so second line it will be hydralazine. Hydralazine will be given 5 milligram IV bolus over 5 minutes. Then every 20 minutes it can be further given for 4 times, so it will be 20 milligram. But after that you have to do maintenance, so maintenance will be 10 gram per hour. Maximum dose it is 40 milligram per hour. Okay, so this is the doses I have. What I'm speaking is from the basic practical skill book. Okay, but if you find any other book, regimen and doses will be different. So like you have to remember one part 3 people, but if you can remember from basic practical skill book, in my opinion that is good. Apart from this, coming to fluid therapy, so fluid therapy we have to do the fluid restriction. So it will be 80 ml per hour, or it will be 1 ml per kilogram per hour. Okay, and urine output minimum it has to be 30 ml per hour. Input output charting has to be done. Consideration for invasive monitoring can be done. If the oliguria develops, that means there is a possibility of renal involvement. This will further cause precipitation of magnesium toxicity. Okay, so we have to be very careful. If urine output has to be minimum 30 ml per hour. If it is less than that, be careful. Stop this thing. Magnesium sulfate, otherwise there will be toxicity. Fluid overload cannot be done. Why? We know, because we are worried about pulmonary edema. Okay, so that's all about it. So this is the full like management of eclampsia from top to bottom, what they want. So you have to speak about every line about A, B, and C. Then you have to speak about magnesium sulfate, everything they want in magnesium sulfate. Okay, and then you have to speak about control of blood pressure. Then you have to speak about fluid therapy. This is the management of eclampsia. In your stations, after that you have to say that once the patient is stabilized, so patient has to be examined per abdominal examination, per vaginal examination. Accordingly you will decide for delivery. This is the whole hierarchy goes for the management of eclampsia. So this covers your one obstetric emergency also. Now few things I wanted to tell. So this is like what is the mechanism of action. So for methyl dopa, it is centrally acting alpha receptor agonist. Sometime for part 2 people this kind of question may also come. So for methyl dopa, it is centrally acting alpha receptor agonist. So because of this central action, so all this depression and all these things occur, side effects are high because of this central action. But because of the central action, blood pressure control is very good. Therefore, in previous days, we used to offer this methyl dopa as a treatment of choice. Now, doses for methyl dopa, I don't think so it is asked in the exam, but it is 500 milligram, maximum up to 2 grams can be done. Now, labetalol, what we are using these days, these are alpha blocker and beta blocker. Okay, mifedipine is a calcium channel blocker, and hydralazine is peripheral vasodilator. Therefore, now you will understand with the hydralazine, it will cause vasodilatation, so it will cause pooling of the blood. So there will be severe hypotension. Therefore, they are doing preloading with the crust 500 ml of crystalloid whenever they give hydralazine. So it is not important for part 3 people. For part 2 it is important because you may get question from here as well. So that's all I had to say. And now any one of you guys have any question can ask me. Otherwise, now that there are the question answer for part 2 people. Any question? Okay, no question, then I'll ask question from you. Okay, now keep on answering. Yes, no answer? Yes, very good. So answer is D. Now you can see this patient is in obstetric emergency. So treatment has to be start A, B, C. So answer will be secure airway in the recovery position. Okay. So start with ABC, airway, breathing and circulation. Very good. So someone wrote A. Why it is A? She's only 34 weeks. Okay. She is only 34 weeks of pregnancy, low risk, and only 5th centile is the fetal scan. So and only trace of proteinuria is there. So why we should not? Somebody wrote A. So why we will not admit her, or why we'll give her administer steroid? That is also not required. We have to keep this woman on monitoring. Okay, so answer will be C.
Ma'am, she has got growth restriction baby and hypertension. Are we going to consider it as preeclampsia?
See,
5th centile.
yeah, see, 5th centile is fine, but umbilical artery Doppler is normal. If you go to your SDA guideline, in umbilical artery Doppler, if it is normal, okay, then they will review this patient after every 2 weeks. Okay, so there is no hurry.
Okay.
According, if you go to SDA guideline, there is no hurry. But yeah, what you have to do, you have to keep this patient under observation. So C will be the answer. You will not deliver this patient today. Okay.
Okay.
Yes. So this, if there is one high risk factor is there, so aspirin has to be given. Okay. So this patient has a previous preeclampsia. Okay. So this, so aspirin has to be given. Yes, it is E. Because she's 41 years old, primary patient, and blood pressure high, mild headache. So just diagnosis has been done. Okay. So when the diagnosis is done, we have to carry out ultrasound at the diagnosis. And if it is normal, we have to repeat every 2 weeks. We have to carry out CTG as diagnosis, and we need to repeat it if it is clinically required, clinical indicated. So answer is E. Yeah, it is simple one, magnesium sulfate. Why? Because hyperreflexic and 4 beats of clonus and severe headache. So there are 2 risk factors. Start with IV magnesium sulfate. These are the options, and this is the question. So you read this, then I'll show you options again. So patient has got generalized clonic tonic convulsion, unconscious, again resuscitate her, ABC. Okay, those who have written D, just see what they're not asking next step. They are asking single appropriate management. Okay, so it can't be D. Yes, it is G only. Labetalol oral. Therefore, reading of the question is very important.
Now question, please. Ma'am, answer key.
Answer what?
Answer key, ma'am. Answers.
Answer I will tell, but someone wrote I. Why
No,
they wrote?
ma'am. I want to see the answer, the list of answers.
Okay, okay. Somebody is giving metamethazole. See, this patient has a 160 and 110 blood pressure. Okay, so this is very high. She is only 30 weeks of pregnancy. Monochorionic monoamniotic twins. High protein urea. Okay, 4 plus. CBC already has been done. Okay, CBC, KFT, LFT they have done. IV access is there. Blood investigation has been sent. Catheterized. She is in high dependency unit. So this is the whole scenario. Someone has wrote K, hydralazine. Why IV hydralazine? Okay, no, it will not be IV hydralazine. It has to, if it is hypertensive, it has to be IV labetalol. Apart from this, before that, you can consider, because in the view she will throw a fit, anticonvulsant has to be started. Okay, anticonvulsant. Prevention of seizure is the next step. So magnesium sulfate has to be started. This patient, you see, she's 37 weeks. She has 140/90 BP and plus 1 protein urea. So she has preeclampsia. She's in labor. Okay, 3 cm dilated. So what you will do? Almost a patient appears to be fine.
Ma'am, magnesium sulfate again?
Why magnesium sulfate? Only 140/90 blood pressure and only 1 press urine.
You will let the labor progress normally? Ma'am,
Yes,
answer.
yes. Just monitor that labor. You need to do the investigation and monitor normal monitoring of labor. Blood pressure has to be seen every hourly. Okay.
Okay.
So find out that kind. That this should be the answer. Either monitoring of labor or blood investigations or 1 hourly monitoring of blood pressure. 3 should be answered. So you have to find out one from there. So it can't be there. It
Ma'am, is it A?
no. Why like
Acha,
so HDU? This is not severe hypertension. Why you want to put this woman in HDU? 140/90 is fine. 140/90 is fine. Okay, so this is what they wrote is blood investigations, and if they write hourly monitoring, that also can be the answer.
Okay.
So this is the question. Okay, she has second eclampsia. She is already like magnesium sulfate is already running for 6 hours. Okay, and okay, so urine output is also okay. It is more than 30 ml per hour. So you can consider giving another magnesium sulfate dose. So another magnesium sulfate, what we give 2 to 4. Okay, so this is the answer. Okay, so who asked why not diazepam? Okay, in the UK people, they only give the medication what we have discussed in the class. They only give magnesium sulfate and antihypertensive. No other medication is given to the UK patients. Okay, so there will be no diazepam. Okay, what is the answer? So now here the patient, she has severe preeclampsia. She is on, yeah, IV hydrolysine is the answer. Because she has got asthma. So you have to give her hydrolysine. What is the answer? The platelet is fine. Yeah, answer has to be hydrolysine, but okay,
Ma'am, why
answer
not?
is, yeah,
Because she is high risk for she's seizures.
yeah, she is high risk for seizures. That is fine because 140, 110, but like tendon reflexes are fine. Salbutamol and steroid. Like what they want to know, magnesium sulfate, severe hypertension. Okay, usually magnesium sulfate is given when the birth is planned within 24 hours. Okay, so here 33 weeks, they are according to the question, they are not planning birth. So main concern is the blood pressure. She is asthmatic, so you have to give it second line. Okay, this is the theme of this question. Now preloading has to be done. This will be followed by intravenous IV hydrolyzing, so L will be the answer.
Okay. Ma'am, is it B?
Yes, it is B only. It is B. For blood pressure, protein, urea, and now you can see they have given PCR, protein creatinine ratio has been given. So if it is more than 30, then it is significant. She has headaches also. Okay, so what you will do?
Plan the delivery within 24 hours.
She's only at 28. Okay.
Okay. Ma'am, is it F?
Better than that, you have to give her IV labetalol. You have to measure blood pressure in patient 4 times daily. And usually like severe okay, that table I have not put in the answer in my presentation, but usually it will be level 2 care. So F cannot be the answer because level 3 is not there. She will be in the level 2 only. So level 2 IV labetalol and monitoring 4 times. So this will be C will be the answer. Okay, if it is severe hypertension, then continuous monitoring of blood pressure all other patients one hourly monitoring of blood pressure. If it is less than 160, 110, okay, then it will be hourly. Otherwise, it is continuously. So answer will be O. And admission, she is already admitted. Okay, this woman is already admitted in the hospital. Her blood pressure now has become fine, and she has having preeclampsia. So what you will do? So you have to monitor her because she's in labor. They're asking intrapartum management. Okay, so in the intrapartum management, blood pressure monitoring for severe hypertension, it is continuously. And if it is only hypertension, not severe hypertension, then it is 1 hourly. This is one thing. Someone wrote F. Level 3, no, it is not. I'll just send you, tell you which patient they want level 3 care. I'll just show you, but she's not for the level 3 care. Okay, so F cannot be the answer. Uh, someone wrote D. So D cannot be the answer because she will not be in the, she is in the labor ward. Okay, and their blood pressure has, their labor treatment has already been started. So blood pressure management in intrapartum. Okay, basic theme is intrapartum blood pressure management. Severe hypertension is continuously, less than that is hourly. Okay, so therefore the answer will be continuous monitoring of blood pressure. Oh,
Magnesium sulfate. Magnesium sulfate.
yes, magnesium sulfate will be the answer. No, no. Blood pressure is high. So answer is labetalol. Ankle reflexes, what they say, brisk ankle reflexes.
Ma'am, she can go under eclampsia anytime.
She can go in the eclampsia anytime. So like, yeah,
We cannot give magnesium sulfate in brisk ankle reflex. Nature has to be good to GSO.
yeah. This is okay. If the knee jerk is creating problem, so magnesium sulfate cannot be given. So answer, okay. Now this is the right answer. So because of knees reflexes, magnesium sulfate is not the choice. So you have to give magnesium intravenous labetalol. Again, their reflexes are brisk.
Ma'am, I'm not understanding this brisk reflexes and magnesium sulfate fundamental, when it's to be given or not.
Okay, so just to remember, usually when the magnesium sulfate is given, there is monitoring for reflexes. If the reflexes are not normal, they are showing any change. So like that is an indication we have to stop magnesium sulfate. Okay, so here they have checked this woman and her knee reflexes are already brisk. That is not normal. Okay, so
Okay.
for this patient you cannot give magnesium sulfate.
Okay. Got
Is
it.
it clear?
Yeah, got it. Absolutely.
So now IV hydrolazine. So what you
Again.
will do? So you have to give crystalloid loading. So she is having no proteinuria, okay? She is having gestational hypertension. So this is a gestational hypertension patient. So, you know, we will not wait for reflexes to totally go before we stop magnesium sulfate. If reflexes are showing any change or, you know, they are getting brisk or slow, then also magnesium sulfate we have to stop. Okay, answer is B. Don't admit this patient. Just take blood pressure and monitor blood pressure twicely. Okay, yes. Now, why answer is this is gestational hypertension because she has got no proteinuria, okay, and she's only having hypertension. Now coming to this chart of gestational hypertension, so she's only having hypertension, so you know, no admission, and you have to measure blood pressure once or twice a week. So therefore this is the answer. Don't admit this patient, monitor this blood pressure twice per week. Okay, so this is now you have to understand that no proteinuria, so it is gestational hypertension. Second, it is less than 160 110, so it is hypertension. So this category, this part of the column will give you answer. So she will not require any admission. Her blood pressure measurement has to be once or twice per week. Therefore, answer is B.
Ma'am, we have to not commence any antihypertensive because she is 143 by 90. And in the chart it is saying above 140.
Treatment is started more than 140/90. So this is almost only borderline here. So maybe in next reading, if the blood pressure shoots up, then the medical treatment will be started.
Okay.
Somebody wrote G. Why you wrote G? Don't admit, treat hypertension, take blood pressure once or twice, take bloods. Take bloods, okay. G is also appears to be good answer. Okay. G also appears to be a good answer. If we consider, you know, that treatment has to be start 140/90. Okay. So if we go to this guideline, so answer will become G. Rather than B, answer will become G from the new guideline. Because they want a treatment above this, they want blood pressure measurement twice a week, they want you to take a blood test. So all three things are coming in option G. So it is G. Do not admit, treat hypertension, take blood pressure twice weekly, take blood test. So answer is G from the new guideline. So now you see blood pressure is very high. So this is severe hypertension, proteinuria, plus like signs of impending eclampsia type situation is coming. So we need to admit this patient, we need to treat her hypertension, we have to take blood test, we have to put the patient under monitoring, and after that we have to examine this patient, and if the conditions are okay, then we have to deliver this patient. So this should be the answer. So this is coming in F. Okay, right answer. Right answer. And if you go to this part, so you have to admit she's a preeclampsia patient. You have to admit her, you have to treat her, you have to do measure the blood pressure every 15 to 30 minutes. But once it is controlled 4 times daily, then then we have to deliver this patient because it is too much high blood pressure for her. Okay. Impending eclampsia, because here impending eclampsia features are coming, frontal headache and spot. So this is an indication where preterm delivery has to be done. Okay, that we just read in the guideline. All on the other side, what they say in the preterm delivery, that steroid thing will also come. So they are putting steroid consultation, and then the delivery has to happen. Okay, that's all for it. So any one of you have got